We're also going to ask you to use the Q&A function on Zoom. So you should see at the bottom next to the chat, there is a specific section for questions and answers. If you wouldn't mind popping any questions you have throughout the talk in there, and it means that myself and Karen can see the questions. We'll get round to answering them at the end. As I said, I'm part of the admissions team, so if you've got any admissions-based questions, feel free to ask those, but I imagine that predominantly it'll be to do with the subject matter in the talk this evening. So as I say, put all questions in the Q&A section as opposed to the chat so that everyone can see kind of what we're on about. Without further ado, then I'm going to introduce our speaker and we'll get started. So this evening, our talk is delivered by Karen Patterson, who is a respiratory and critical care doctor trained in the US, but living happily now in the UK since joining BSMS in 2017. Her research focuses on elucidating mechanisms of sterile inflammatory response in the lung, particularly on a disease called sarcoidosis, which complement her prior work as a sarcoidosis and interstitial lung disease expert. At BSMS, she teaches respiratory medicine and leads a variety of small group sessions for phase 1, and is also a member of several committees and groups across the medical school and the University of Sussex. As well as all of that, she's also a visiting scientist at the Francis Crick Institute, where she explores the relationship between lymphatic function and inflammation. So without further ado, Karen, I'll hand over to you. Take it away. Thank you.
Hi, thank you. So thanks for that introduction. And I'm excited to give you this talk today, which will actually be nothing about sarcoidosis or interstitial lung disease, but I am going to draw on my experiences as a respiratory and critical care doctor and sort of my being enmeshed in the world of respiratory and critical care and what I've sort of heard from colleagues over the past couple of years in regards to the pandemic to give this talk today, which is understanding vaccine hesitancy, and where I will pose this question: is there room for respect for patients who are vaccine hesitant? And this is going to be a talk where I talk a lot about COVID vaccine hesitancy, but I don't want this talk to only be focused on COVID. And in fact, I'm going to breeze over a lot of issues related to COVID with the understanding that you probably have heard talks or have some understanding of the coronavirus itself, and that you have some understanding of the disease process of COVID, the signs and symptoms and outcomes associated with it, and that you have heard about the tremendously the tremendous efficacy associated with the vaccinations that have been approved for COVID vaccine and the decreasing death rates that we've seen associated with deployment of this vaccine program across the country. So, but what I want to talk to today is where we're stuck with sort of reaching our full potential in regards to vaccination and how we might learn from the experience of not being able to reach all of our patients, and how the lessons learned from vaccine hesitancy may apply more broadly in conversations that we as doctors have, or we as healthcare providers have with patients who may make decisions that we don't agree with, and in fact may make decisions that are counterproductive to their own health goals. So without further ado, I will get started, but I'm going to start with a disclosure statement, which is that I have nothing to disclose in regards to funding, but I do think while I'm going to present a fair number of facts throughout this talk, this is essentially an opinion talk and my opinion. And so just so you know a bit of sort of who I am and where I stand in regards to the vaccination. So I've been vaccinated. I've been vaccinated twice. I have not yet received a booster, although I suspect that's in my near future. I did have COVID over the holidays, so I one could consider that possibly a booster. And that is not meant to be a controversial statement, but I do realize that in some circles that could be considered as such. I also am, firmly enmeshed in academic medicine. So I put a lot of faith and confidence in data, robust data, particularly data that can be reproduced across time and across groups, and that is reassuring for me. And yet, I also hail originally from parts of rural America, and there is a reputation, and in part it's well-deserved, that reliance on big data may not be as reassuring at a personal level for making decisions about health. And so I have a fair amount of empathy for people who make different sorts of decisions in their lives and in their healthcare, and in particular in regards to the COVID vaccination. And so I have not heard in my circles, I haven't heard a lot of acceptance for different sorts of opinions, and I'm very interested in, promoting discussions. I'm not interested in promoting acceptance of vaccine hesitancy, because I believe the vaccines are so tremendously valuable in preventing death for some patients. But I am promoting conversations to be had. And so without further ado, we'll get into it. So as you know, we'll start with, oops. There we go. We'll start with this date. So we'll go back to December 8th, 2020. So the first COVID vaccine was administered to someone in the public in the UK. So we were the first country to roll out a public vaccination program. That's commendable. And this is the picture of the first patient getting vaccinated in early December. And following this, we deployed a vaccination program around the country, and we quickly started to vaccinate a large percentage of our population. As I don't know if I should look at the chat questions as they come up as we go. So Matt, unless you tell me otherwise, I'm just going to keep going unless it's something I need to know, like you can't hear me. Okay, that's in early December. Now we fast forward to January, the next month. We have 10% of the population that's been vaccinated, at least with one dose of the vaccine. Another couple of weeks, we're up to 20%. Another couple of weeks, we're up to 30% of the population. Another month, we're up to 40%. We get to 50% by April. We get to 60% by early summer, and we get to 70% of the population has had at least one vaccination by the end of August. So within a relatively short period of time, we vaccinated a large percentage of the population. Now, this is the entire population, not just the eligible population. But if you were to follow this curve out, you'd say, okay, all we need is a bit more time and we'll reach all the people that we need to reach, and 100% of eligible people will become vaccinated in this country. And so we go from August 2020 and we fast forward a year and a half, and we see that, yes, we have made some gains, but that we have not, in fact, reached 100% of all eligible patients. So here we see that 70% of the population, 76% of the population, if we look at single vaccination, has been vaccinated. And this is as of last week. And you might be asking, okay, well, how does this fit into total eligible patients? And so if we look at total eligible patients, we're doing pretty well, but we're not at 100%. And so this is across the UK. So 91% of people who are eligible to receive the vaccine, so that's people who are 12 years and older, 91% have had at least one vaccine, and 84% are doubly vaccinated. That's impressive. That's impressive. And yet, I would argue that missing 10% of the population is still an important 10% to reach. And I would also argue that we have a little bit of work to do locally. So if we look at Brighton and Hove, the numbers drop a bit. And so we have a lower rate of vaccination compared to the rest of the country. Now, this is potentially slightly unfair in how we count vaccination rates. So areas that are counted by the ONS for vaccination, areas that have a highly transient population, so this would include our population of students who come and go, may lead to undercounting of vaccinations. And so you might say, okay, well, if we took the sort of student population out of it, we'd have higher numbers, and we would have slightly higher numbers, but we still wouldn't reach national averages. And so if we look across Brighton and Hove, and we look at age groups here on the y-axis, over time on the x-axis, we see that those patients who are 75 and older are highly vaccinated. There, we're approaching 100% of patients being vaccinated. But if we're looking at groups that are under 75 years of age, we see that across the board, we're not reaching our full potential. And it's not just the very young adults that are not getting their vaccinations. It's really all potential age groups that could be outreached to increase vaccination rates when we're talking about people who are under 75 in our region. Now, at this point, we've had enough time. So it's been a year since a year plus since we've rolled out the vaccination. We have very good access to medical care in this country. And so when we're talking about 10% of the population, approximately 10% of the population that has not been vaccinated, at this point, we're not thinking this is a question of access or a question of not enough time, that patients just haven't had the opportunity to get a vaccine. Now we're concerned about vaccine hesitancy. And so I'll turn my attention to sort of looking at vaccine hesitancy. So where does the UK fall sort of across the board in regards to vaccine hesitancy? Well, actually, we're pretty good. So, our 10% of the population is lower than most other countries around the world. And this is data from a year ago. We do know that vaccine hesitancy has actually improved a bit, that these numbers are slightly lower than they were when this survey was conducted in early 2021. And so we are relatively low. And yet I would argue that this approximately 10% of the population is still an important challenge for our medical community. And it's an important challenge for a couple of reasons. First, that 10% of the population is a large number of people who are at risk of having a bad outcome from COVID. This is not just a strain on the NHS, although it is a strain. But this is also, this is a social and psychological strain for families when family members become sick or die as a consequence of a preventable illness. And it's a strain for the individuals who get sick and will suffer during these illnesses. So I think we care about these people, even though they're not making decisions that we would make ourselves or would recommend for them. There are also arguments that this 10% will impede our efforts at reaching herd immunity, if that's possible. And if it is possible, certainly this 10% would be critical to reach. I would also say, and sort of step back from this and say, kind of beyond the COVID vaccine question, are there larger lessons to be learned from this experience where, doctors are interfacing or healthcare providers are interfacing with patients who are making decisions that are difficult. They're difficult because we see the consequences of not being vaccinated. We see the suffering that it entails, and we know that it's preventable. That's really hard for physicians to see and not sort of have an emotional response to. But are there lessons that can be learned from this experience that might be applicable to other difficult discussions that we have in clinics with patients about other topics not related to the vaccine? So that's sort of one of my overarching interests for this presentation. So I was tempted to just launch right into how do we address vaccine hesitancy? What are the sort of tools and tricks that we can use? But what I'm going to start with first is sort of understanding vaccine hesitancy, because if we don't understand it, it's going to be hard to know which possible tool we could apply to dealing with our patients. And so understanding vaccine hesitancy. So who are the vaccine hesitant? Well, there's sort of a survey of the features of patients who identify as being somewhat or very hesitant to receiving the COVID-19 vaccination. And what we see is that young adults are more likely than older adults to be vaccine hesitant, although this has improved as the pandemic has unfolded, which is to say that younger adults are becoming less vaccine hesitant. But ethnic minorities are still quite hesitant compared to other groups to receiving the vaccine. So the highest rate of vaccine hesitancy was observed among ethnic minorities. Vaccine hesitancy was also higher for adults who identified as Muslim or another religion compared to adults who identified as Christian. And adults living in the most deprived areas of England were more, 8% of those were identified as vaccine hesitant, and 12% who are unemployed, and there may be some overlap there, also identified as being vaccine hesitant. So these are some of the clinical features or characteristics of people who are hesitant for the vaccine. But what are the reasons? What are the underlying reasons for that hesitancy? So this is not going to be a comprehensive list, but these are the topics that I wanted to address in the upcoming slides. Again, I saw that someone had your hand up. So if there's something that I should be addressing in real time, and I'm happy to do so, Matt, please just let me know. So reasons for vaccine hesitancy. So there are potentially a large range, but what I want to cover here are being underinformed, what I might consider to be underinformed from a patient standpoint, being misinformed, having what I would label as conspiracy mentality, mistrust of the medical establishment, lived experiences, and needle phobia. And I did put conspiracy mentality in red because that for me is the most difficult sort of reason for vaccine hesitancy, because it may be the most sort of difficult to also sort of change. There's a lot of sort of fixed beliefs associated with that. And sort of as a medical provider, that may be where we're least able to be successful in convincing our patients to consider a vaccine. So taking these in turn. So when patients come to us and they, and they indicate that they just don't know enough about the vaccine to get it, I think that's a wonderful opportunity to produce some counseling about it. If we don't have time in clinic to go over some of the details of the data and support of both the efficacy, but also the safety of the vaccine, we can refer patients to the NHS website. There's a lot of very clearly presented, easy to read information on there about these vaccines. Now, patients don't always come in and say, I don't know enough about the vaccine. That's a pretty clear statement of an unknown, but they may say it in different ways. They might say the technology is too new. These are all the technology is too new. That might appear as a statement. I view that as a question. They're kind of probing, is the technology so new that it's potentially dangerous. And I think that's an opportunity for us to respond. The technology is not new. The application of this technology to vaccines is new, but the technology itself is not new. The clinical trials were rushed. So we hear that a lot. The clinical trials were rushed. I view that again as a question. Were the clinical trials rushed? What does it mean to go through clinical trials? Phase 1, phase 2, phase 3. Most patients don't know about this. They've done a little bit of reading on the internet, but they're not usually well versed on clinical trials. And so when they say they're rushed, I view that as an opportunity to provide some clarification about how clinical trials are typically performed and how these ones were actually not in fact rushed, but some of the phases were merged. And then some patients will say things like, we haven't had enough follow-up data. I think at this stage, we're probably not hearing that as much because it's 1 year plus, into the vaccine rollout. So, billions of people around the world have been vaccinated. So we do have follow-up data, and I think most patients are aware of that. But I think early on, there was some concern that there wasn't enough data to sort of claim that the vaccine was safe, sort of in real-world practice. So that's all under information. And I view that as sort of probably easy opportunities to engage with our patients in a very non-judgmental, calm, non-emotional way to sort of say, I'm glad you asked that question. Let's just talk about that for a minute and see if I can clarify a few things for you, right? So, but it requires the physician to be informed, and I'll come back to that point at the end. So misinformation. So this is not necessarily missing information, but a misinterpretation of particular facts and the use of particular facts about the vaccine in ways that lead to misinformation or misunderstanding. So, we've had patients say things like the lipid particles will cause antigen to spread, which is a very technical thing for a patient to say. And I don't think there's a immunologist or a biochemist coming into your office who will say these things. So these are not people who typically know a lot about lipid particles or antigen, but so they've done some reading. And so they're coming in with some a bit of jargon, but also maybe with what they might consider a bit of knowledge, but it's sort of misinterpreted and certainly being misapplied in regards to evaluating the vaccine. We've heard that vaccines could change my genome, right? And so this requires us to be able to distinguish with the patients the difference between, RNA and DNA, and have discussions about that. I still view these sorts of statements as opportunities for sort of information sharing and to clarify, what I might consider misconceptions. Patients may be slightly less open to receiving these. This is not a flat out call to please inform me about the vaccine. They may not have asked for their statements to be clarified, but I would view those as such. But again, in a very non-confrontational way, non-emotional way. There are these statements here, which I still would put under the category of misinformation. So I'm allergic to eggs. The vaccines that we use in this country are not grown in eggs. So this is, non-relevant to the current vaccines here. There are some vaccines for COVID that are being developed in eggs, but not in this country. Vaccines make me sick, and that might be an experience that they've had. We have to do some education around what it means to have a reaction to the vaccine and to actually be infected from the vaccine. So this is sort of a misinterpretation of events following the vaccine. Patients might say, I could die from the vaccine. And technically, this is a true statement. They could die from the vaccine. The chances of them die is so tiny. And so I would consider this sort of a misextrapolation of the data. And so I think this, when patients say things like this is an opportunity to actually give some numbers on the number of people, fewer than 10, in this country who have died from an association with the vaccine. Where the cause of death was thought to be linked to the vaccine. And they might come to you and say, well, the case fatality rate for COVID is actually just so low that it's not worth getting the vaccine. And they might come to you and say the case fatality rate is less than 1%, which it is less than 1%. We do know that now. We were wrong about that at the beginning, so we need to own that. But it doesn't mean that the case fatality rate is low, and it doesn't mean that not lots of people are dying. And that's the point. The case fatality rate can be low and lots of people are dying. And so we need to be able to let their statements stand and just address them head on. So that's under the category of misinformation. And then we get into conspiracy mentality. So here's a study looking at conspiracy thoughts in a UK population. This is a survey of adults across the UK and found that there was an association between coronavirus conspiracy beliefs, and they looked at specific and more general coronavirus conspiracy beliefs, and the difference between those does not matter for the purposes of this talk, but just to say that there was an association between deeply held religious beliefs and conspiracy beliefs, and there was also an association between the amount of time that people spent on amplifying social media outlets and conspiracy beliefs. And so it may be hard for us to have a conversation with a patient in the office and change their mind because they're getting a lot of reinforcement about their beliefs outside of that, outside of the clinic. And so they're getting a lot of reinforcement about that in social media platforms and potentially within their religious communities as well. And so that's why I think this particular group may be particularly difficult to break through in regards to providing true education about the safety and efficacy of the vaccine. But one thing that was interesting to me in this study, and this is more data that was, this is other data that was published in it, is that there seems to also be an association between conspiracy beliefs and mistrusting of various groups of people. But here I'm just going to highlight there's an association, an inverse relationship between a conspiracy, tendency towards conspiracy beliefs and trust in doctors. And so you could say there's an association between conspiracy and mistrust of doctors. And that's what I want to focus on next. So not all patients who have mistrust of doctors or the healthcare system are engaging in conspiracy beliefs or hold conspiracy beliefs. But I do think that to the extent that it's possible to identify areas of mistrust, we could tackle those head on. And even for patients who don't have conspiracy beliefs, we may still need to address mistrust in the medical association, in the medical field, or in the medical profession to help patients trust us when we tell them, we think you should take this vaccine, that this vaccine actually could save your life, and that this vaccine is very likely to cause you any real harm. They need to trust us before that is something that will result in increased vaccination uptake. So mistrust in the healthcare community or the medical establishment. So this is growing in certain segments of the world. As I will review at the end, there's still there's still high trust among the UK public for doctors, but there is growing mistrust of the medical profession. In many parts of the world, this could be demonstrated. So this is an article from the New York Times. So this is, sort of looking at a US population, but this question, I think, is applicable to more than just the US population. So growing mistrust, and this matters because we know that when patients have poor trust in the medical profession, this actually, this affects their outcomes, right? So this is something that's can cause them harm. So their mistrust and our earning of that mistrust causes patients harm. So this is a patient that I just put the date here, that this is a paper that predates the pandemic. So this is possibly, so mistrust is possibly widened in the meantime. So what I wanted to explore in the next few slides was origins of mistrust, because as I alluded to, some of this mistrust has been unfortunately well earned. And I think that as a medical profession, we have to sort of own our legacy. We have to sort of own what we've done and what we've failed to do for our patients over time, because they come with real memories and real experiences, and in some cases, real trauma of things that have happened in the healthcare setting that did not lead to them receiving high quality or equitable care. And so origins of mistrust are largely rooted in biases and prejudices, although there are a few other things that I'll touch on as well. But first, biases and prejudices. So there's a large range of biases that impact the type of care that patients can or have received. And the list is long, and I'm not going to get into all of them. And in fact, there could be a talk on this topic alone. But biases include racial bias, gender bias, sexual identity, sexual orientation bias, gender identity bias, physical disability, mental illness, weight or physical features, biases against those, age bias. The list goes on. Socioeconomic bias, immigrant bias. So quite a long list, and that will encompass the large percentage of our patients could fit into one of those categories. And so I think not to acknowledge that when it's important to acknowledge that is a missed opportunity to build trust or regain trust among some of our patients. I'm just going to give examples of some data for 3 of these. So I'll start with racial bias. So here's a study out of PNAS looking at sort of racial biases or beliefs in young doctors or medical students. So this was junior doctors or medical students. And they started this study with the premise that beliefs about there being fundamental differences in biological function based on skin color alone was widely prevalent in the general population. And so they looked to see, was this also widely prevalent among medical students or young doctors? And they found that it was. So 73% of the people that they surveyed indicated some belief, some type of belief that indicated racial bias, 73%, upwards of 73%. So and this is a recent study. So that's a tremendously important finding. And this bias matters. This bias affects outcome. And so here are just two papers, although I could have put up many, many more. So here's just an example of two papers looking at how racial bias had an impact on medical care and outcomes. And so in the top right, they were looking at how pain treatment was delivered in relation to race, and saw that Black patients were much less likely than white patients to receive adequate pain treatment. Another way to say that is that Black patients, compared to white patients, were much more likely to suffer. And the bottom right paper, they were looking at patients who presented with various medical issues, but including cardiac conditions. And Black patients compared to white patients were much more likely to be admitted to a general medicine service compared to a consultant medical service. So in this case, a cardiology service. And it's known that outcomes are better for patients who are presenting with cardiac issues who are admitted to a cardiac service. And so admitting patients to general medicine service has a real impact on outcomes. So that's racial bias. Next, sexual orientation and gender identity bias is rampant. I could put up lots of studies and papers for this one as well. But instead of putting up those individual ones, and instead of putting up numbers and pie charts, I'm just going to give you a few quotes from a review. And so I just give you a moment to read these, and I just highlight 3 of them in red. So here's one of them. Here's another one. And here's another one. I think we all know this happens, but it's hard to read these stories. It's hard to read these and know that these are still happening, and that this has been happening recently, and that patients are really experiencing this. This is not subtle bias and stigmatization or discrimination. This is active discrimination and bias. So finally, I'll end with weight bias. I just chose this one because I thought this might become more of an issue with the COVID pandemic and the focus on obesity as a risk factor for poor outcomes. I thought possibly this could lead to more fat shaming. It has a little bit in the US, but regardless of that, just wanted to put it on your radar because it is something we're appreciating more, that patients who are overweight or obese experience more stigma in medicine and receive lower quality of care in medicine, and that their outcomes are affected by this, independent of the comorbidities associated with being overweight, and that there's a strong association with being overweight and being unhealthy, which may not be true, that you can be, just because you're overweight does not mean you're unhealthy, but that this is the stigma that patients are experiencing in medicine. So when we talk about bias in medicine, a lot of that may be implicit or subconscious. Now, there are things that have happened that are not implicit or subconscious. There has been overt medical misconduct, scientific misconduct at the hands of doctors and scientists, but doctors who perform research and either falsify data or falsify the interpretation of studies and data. This, in some cases, leads to retraction of articles. And patients are aware of this. Not all patients, but some patients are aware of this. And so even if we're not involved in these studies, which most of us won't be, and even if we don't know these scientists, I personally don't know anyone who's been involved in medical misconduct that I'm aware of. But still, our patients are hearing these stories, and it can lead to further mistrust in how medical research is conducted and how data is interpreted and how recommendations are given to patients. So less egregious than frank misconduct is conflict of interest issues, which is here on the right side. So conflict of interest is the existence of conflict of interest is a fairly widespread problem. And we've been grappling with this for now quite some time on how do we deal with doctors who also engage in research and may have financial relationships with pharmaceutical companies. They are involved in writing papers and presenting the data, and they may even be involved in guideline statements where they may be in guideline statements making recommendations for medications that they get a kickback for. So that's that's an obvious conflict of interest. But that's something that up until recently was not largely spoken about and acknowledged. So we're getting better about that. We do acknowledge these conflict of interest, or at least we are asked to do so when we submit papers, when we give talks, when we serve on panels. But I don't know that we're always so transparent when we talk with patients. I don't think the large majority of doctors who get money from pharmaceutical companies, for example, are revealing that to their patients. And so this, is a question. Should we start to be more candid with our patients about this and at least address the issue of conflict of interest? Sometimes I address it with my patients by saying, I don't have a conflict of interest. I don't have a financial relationship with any of the companies that make the medicines that I'm recommending for you. And I think that's important that you know that because I have heard over time, a growing awareness of this. And I think this can contribute to some of the mistrust of medicine. Okay. And you could say, well, are these relationships important? And it turns out, yes, they do. They affect our behavior. And so this was a recent review of many studies and found that across the board, that providers who have a financial relationship with pharmaceutical companies prescribe their medicines more, and there's a dose response relationship with that relationship. With the more they're paid, and so this is widely reproducible. And this is a recent review. So you might say, oh, well, we should, it's good. We're just learning about this, but we're not just learning about this. We've known about this for a long time. So I don't know if you can see this there, but that's a study above looking at this issue back in 1994. So we've been talking about this issue for decades. We still have not fully dealt with this, and patients are aware of this. And you might say, how widespread is it? And the answer is it's very widespread. So here's a survey looking at US physicians, and nearly half of US physicians received some sort of payment from industry, and largely from the pharmaceutical industry, totaling over $2 billion. And you might be tempted to ask, as I was, oh, well, I'm sure most of that was research related. They got money for doing research, or this was to promote research programs, and only 4% of this money was related to research activities. So the rest of this was just flat out payment for being, a guest speaker, on a topic that had to do with their pharmaceutical, or payments to go to talks, to go to conferences, whatever it is. But sort of payments that, if patients knew about them, would probably not be comfortable with, and that could contribute to this mistrust of the medical establishment. Now, you might be saying at this point, wow, it sounds like the US has a problem with it. And we do. We have a huge problem with it. But it's not just the US. And so I'm going to skip over that one. I'm not sure that's so essential right now. We also have this issue in the UK. And so, looking at sort of healthcare staff and organizations in the UK, there's still relationships with pharmaceutical agencies and financial relationships that could affect prescriber information. And you may know about this book, Bad Pharma, which looks at pharmaceutical trials across different countries, but includes work in the UK. And these were some of the concluding points of that book, that companies are intimately involved with trial design. So they're involved in evaluating their own products. So there's a conflict of interest there. There's an incentive for them to find positive results. And in fact, there's a history of them bearing data when the results are not positive or flattering. Government regulators who evaluate this data haven't always been fully transparent and forthcoming about the results when they have them. And so this has led to mistrust of the medical establishment at a government level, where we would supposedly provide oversight for these pharmaceutical companies that do what we might consider to be unethical behavior. or at least, that would need some regulation. Doctors groups, we could say patients groups as well, but I'm interested in doctors here, have been known to take money and receive favors for speaking on behalf of pharmaceutical companies and promoting certain medications. So in many ways, we could sort of conclude that pharma influences pharmacy education and pharmacy approval in this country and elsewhere. And so this is something that I think we need to address and at least acknowledge. It doesn't mean you need to be involved and advocating, at a government level of how we regulate drugs. But when patients come to you with these concerns and say, I've heard this has happened, the answer is yes, it has happened. And it's very concerning. And to the extent that it's possible, you are going to provide information that is as unbiased as possible and that you're aware that this history exists. And this is relevant because when it came to approving these the two COVID vaccines by Moderna and Pfizer, there was this report in the BMJ, which has done a fair amount of work looking at how medications are approved and the transparency issues around that. But in regards to the vaccines in particular, they published this report. There was sort of a leak that there was some concerns about the integrity of the messenger RNA, that a fair percentage of the messenger RNA some of the batches that were delivered for evaluation were incomplete. And so, an incomplete messenger RNA strand is not going to produce a protein product. And so you need to know the integrity of the messenger RNA as you make decisions about vaccine efficacy and approval. And when it came time to asking Moderna and Pfizer to comment on this, both of them declined flat out to make any comment. But then when it came, when we moved beyond the pharmaceutical agencies and there was a comment that was requested by the MHRA, they also declined to comment on that. I don't think that builds trust. And maybe in the moment they needed to take some time and gather the data a bit more, that's fine. But, there hasn't been a true acknowledgement of this issue even now. So I think that for those people who are aware of these sorts of problems, this will not instill confidence in how the vaccines were approved. We can tell them all about the efficacy. We can tell them that the numbers are really good for preventing severe infections. But when they have this in their mind, that the data may not have been transparent or the evaluation may not have been transparent, it's hard for patients to overcome that if this is an issue that concerns them. Okay, so now I'm going to move on to something beyond just mistrust and concern about transparency, but I want to acknowledge something that I couldn't come up with a better term for it, but I wanted to say, patients have these lived experiences, and there is some discrepancy between what we've been messaging, we as a sort of large sort of healthcare community, at the government level or at a hospital level, at a trust level, or even as a personal doctor, clinic level. We've been saying certain things, and patients are seeing that some of what we're saying is not matching up to what they're experiencing in reality. So, in the beginning, we sort of said that the vaccines were good at preventing infection. They were preventing death, preventing serious infection, but we also said preventing infection. And now we know that that's not true, right? So that you can have all the vaccines against COVID in the world. You could have many, many vaccines, and you could still get the virus in your nose. You could still test positive for the virus. There's nothing about having antibodies in your bloodstream. There's nothing about being vaccinated that prevents that exposure from happening, and from a little bit of viral replication from happening. That seemed evident from the beginning, but the messaging was that these vaccines were, very, very effective at preventing infection. And we said, well, they're not 100% effective, but what we meant by that was, this efficacy of 95%. Meant that a few people would still get infected. And what I think we're realizing now is that low grade or asymptomatic infection can still occur very, very commonly in people who have been vaccinated. This will not prevent you from testing positive. And we didn't say that at the beginning. We kind of made the point that you won't get sick if you get the vaccine. And I think, or you most likely won't. And I think sort of acknowledging that is important, because people are coming now and they're saying, well, I could still get sick, so what's the point of getting the vaccine? And the point, of course, is that you won't get seriously sick and you likely won't end up in the hospital or die. That's the point. And so these are just quotes from the CDC in the United States, or the NHS here, saying that the vaccines will help reduce the risk of you getting COVID. So, and that's a message that I think most people are saying, my lived experiences, I got vaccinated and I still got I got vaccinated, I still got COVID, or, my colleague got vaccinated and they still got COVID. And so it's sort of decreasing sort of trust there, you could say. Another lived experience, the second example of this is that we were told that if you get vaccinated, you won't spread COVID, you won't spread the coronavirus to others. And so some people got vaccinated just as a sort of public health, as a public good, right? And now we know that that's not true either. And so there wasn't a blanket statement that you absolutely could not spread it, but there was strong wording suggesting that you wouldn't spread it. So here's a picture of a video put out by the UK government saying, get the vaccine, not only to protect yourself, but to protect others. And here's a statement from Johns Hopkins University in the US, that getting vaccinated helps you protect others. And the lived experience is that you can still give COVID to other people, even if you've been vaccinated twice or thrice. It seems that you're slightly less likely to pass it on, but I think we need to be honest about this. And I think we need to if we need to backtrack, that's okay. Early on in the pandemic, we didn't know everything we needed to know. So as long as we're honest with our patients and say, yeah, funny, we weren't quite right about that message. What we were right about was it reduces the risk of death massively. It reduces the risk of you ending up in the ICU, ending up on a ventilator. That's the message we need to be consistent with. And so when we weren't quite right with the other ones, I think that would be helpful. The third part is that, and this is a little bit trickier, but we really sort of downplayed the efficacy of actually having the COVID infection. We don't want people to depend on natural immunity. We don't want people to get infected as their way of being protected against future infections. We want people to get vaccinated. But I think in the process of doing that, we've discounted the fact that actual natural immunity is important. There's no reason to doubt that it wouldn't be long lasting and also strong. I am an immunologist by training as well. And so it's hard for me to hear that natural immunity is not as good as the vaccinations. I don't think there's strong evidence for that. I don't recommend that anyone go the natural immunity route, but I think we need to be honest with our patients when they ask questions about that. And there was a recent study that came out. So this is recently published, looking, at outcomes for patients who had been infected with COVID or had been vaccinated against COVID, and actually shows that natural immunity is actually okay. It's not a program we're recommending. I want to be very clear about that. I don't think it's okay to go that route. I'm not a promoter of COVID parties, but I also don't want to discount when patients come in and say, I've had infection. I've had it in the past, so I probably have some degree of protection. And the answer is, yeah, you're right, you do. But you could have more if you got the vaccine. So that's kind of where I'm hoping we can meet patients, is by not discounting their experience and not discounting their lived experience or what they're hearing their friends and neighbors talk about. We've also had an issue with sort of this quickly changing messages and recommendations. I don't want to get too much into that because, again, I kind of want to cut us some slack. Like this is a totally new pandemic, and we're kind of finding our footing with that. But I do think we could also be honest with patients about that. So the final thing I'll end on is needle phobia. And so this is a little bit on a personal note because I'm one of the 26% of adults in this country who identify as being needle phobic. And I have a tremendous phobia of needles. So I have a lot of sympathy for patients when they have this. And so I actually find that very helpful. And I can ask patients about it. And so this is a study that looked at what percentage of the patients, have some needle phobia. So that was, again, 26%. And they did a very fancy analysis, which you'll see there on the left, trying to input the weight of fear of injections, FOI, into vaccine hesitancy. It's a very complicated graph, which I can't even dissect for you in its entirety. But just to say that the fear of injection or needle phobia does actually contribute to vaccine hesitancy in this country and probably around the world. And here, if you look on the right side, the chart on the right, the graph on the right, you see that fear of injection, so again, needle phobia, increases the odds ratio of being hesitant for vaccination, and significantly so. So the odds ratio of 1.55. And so I just ask patients if they haven't got the vaccine, how do you feel about vaccinations? Are you have any issues with needles? And I tell them I have it. So no shame. And in fact, I use lidocaine patches before I get the injections. It helps me. But there's things that we can offer patients, and the NHS has actually done a pretty good job of this. So we have, you can have special sessions booked with nurses at the vaccine clinics, where patients can go for desensitization training, or they can go for longer periods of time for their vaccination, so they're not rushed through. And so actually, we're good at accommodating that. So I think recognizing it can actually lead to recommendations to make it easier for patients to get the vaccine. So I just wanted to put that out there. I don't think that's going to fix everything, but I do think that's a small component that's relatively sort of easy to talk to patients about, because most patients will admit it when they have it. Okay. So how do we actually address vaccine hesitancy? So I've given you all the reasons why I've given you many reasons why patients may be hesitant, but what do we actually do about it? Clinical practice, like how do we overcome this? So, one way, this is not clinical practice, but one way is that at sort of a societal level is with mandates. And so as much as people say, I'm never going to get the vaccine, we do see that when mandates are implemented, vaccination rates go up. And so saying you're never going to get the vaccine is slightly different than truly not getting the vaccine. Some people still hold out, but mandates do help increase vaccination rates. Now, we are doctors, most of us. We are not policymakers, or some of you may also be policymakers, but I sort of view my role with patients as providing them with as much information as possible, with trying to understand why they're not getting the vaccine, but not coming down heavy-handed. I'm going to let the policymakers come down heavy-handed, and they do the mandates because it doesn't help the doctor-patient relationship to sort of come at it from this level. And in fact, there's some concern that actually heavy mandates may backfire. You may inspire patients, if they want to keep their job or for whatever reason do get the vaccine, to get the initial series. But it may be counterproductive in regards to long-term vaccination goals and or even for boostering. So anything that's not mandated, there may be even more reluctance to get that in the future. But mostly my main thing here was just to point out this is a public policy issue. So, we don't get involved with mandates. So when we talk to patients, I think we can have very calm, non-emotional discussions with our patients and, do some probing as to where they're at, how they arrived at their level of understanding, and to see if there's any way we can reach them where they are without getting into the whole mandate discussion. Like I wouldn't tell a patient, you should get the vaccine because it's mandated. I would come at it from, you're my patient, I really care about you, and I don't want you to die. I think that's why you should get the vaccine. And if you have any questions, I'm here for you. And in fact, I saw this. If this hadn't been several hours away, I would have gone yesterday because I was curious how they were running it. But up in Norwich, they ran a clinic for patients who were concerned about the vaccine. So you can just go and ask questions. I think that's great. I want to see more of these where we can sort of have community sessions where patients can come, ask their questions, get some answers, and hopefully not feel so alienated by the fact that they haven't yet got their vaccine. So just putting that out there. There was a survey done looking at what we could possibly do or tell patients that would increase vaccination rates. And so there's been this OCEAN study that's ongoing by Oxford. They did OCEAN 1, 2, and 3. OCEAN 1 was the conspiracy mentality data that I presented earlier. OCEAN 2 was doing a survey of adults, and for those that identified as being hesitant for vaccine, seeing which messages would most likely sort of move the needle, as they called it, and make them more likely to get vaccination. And it turned out that personal benefits, when it was pitched as a personal benefit, were much more likely to increase the likelihood of them reporting that they would be open to getting the vaccine versus using collective benefit arguments. And then and instead of moving this beyond just a survey, then they then did a trial where they actually provided different sorts of counseling interventions to patients. And for those patients that were vaccine hesitant, interventions that again focused on personal gain or personal benefit were those that were most likely to result in a reported likeliness of getting the vaccine. And so when we looked at both of these, addressing personal beliefs was the most efficacious way of getting patients to at least report that they would be more likely to get the vaccine. It's not actually showing whether they got the vaccine. Okay, so moving on from there. So I'm going to end with this point. I think we could also do some work with continuing professional development, because what I focused on before was a lot about the patient and sort of how we can pitch things to them. Now we could do some continuing professional development in regards to how best to reach our patients. And so we could learn some lessons from social psychology. So there's different approaches that have been tried in other sorts of counseling opportunities and areas. So for example, behavioral change related to dietary changes or increasing exercise or smoking cessation. So there's the nudge approach. There's behavioral change techniques. There's a whole research field for this. I don't think as doctors we get a lot of education about this. And so it's kind of like we all kind of make up our own approach as we go. That's my understanding from my colleagues. And so I think, maybe some education in this could be very helpful. I'm going to skip over this in the interest of time, but this is just going over the nudge approach. And this is just getting at whether we should go with the carrot or the stick approach. And it appears that we should try to be as carrot oriented as we can. I think the other thing I would say is that, we should be aware of where we've made mistakes in the past, not just with mistrust, as I went over, but also with some mishaps with vaccine. And so in the US, in the year of my birth, 1976, we had a swine flu concern. It was labeled as a swine flu pandemic, but it wasn't a pandemic. But there was one swine flu death. There was concern this would reach pandemic levels. And there was a very, very fast rollout of a vaccine against swine flu that led to a high number of cases of, hundreds of cases of Guillain-Barré syndrome that were associated with the vaccine. This pandemic never occurred. There were no other deaths from swine flu, and 25% of the population, so over about 40 million adults in the United States were vaccinated for something that was probably not necessary, and that led to substantial morbidity for the patients who came down with Guillain-Barré syndrome. There are a number of people that I have seen in clinic who remember this. And so we need to remember this. And so to say that vaccines are safe, yes, most vaccines are quite safe, and we have a lot of data for it, but we also need to remember that, actually we have made some mistakes with vaccine rollouts before, and we can acknowledge it and learn from that and acknowledge our patients that we have learned from that. The third area where I think we need continuing professional development, and this is probably the main area where we need CPD, is actually for vaccine knowledge. And that's why I put that one in bold and in red. So when I talk to my colleagues, most of them they don't have a very good understanding of the difference between vaccine efficacy and vaccine effectiveness. I don't know that your patients will ask you about that, but they are going to ask you about liposomal preparations. They may ask you about these messenger RNA vaccines being completely new, which they're not. They may ask you about the differences between different types of vaccines. They may come to you and say, I have an egg allergy, I'm not getting the flu vaccine. And you could say, yes, most vaccines for the flu are made in eggs, but a certain percentage aren't. And we have cell culture techniques, for example, that are alternatives. And I will say that this is not to throw anyone under the bus, but most of my colleagues don't know about vaccines in a real way. They've read the New England Journal of Medicine articles. They've read the JAMA articles about these vaccine trials. They know that they are 95, 94, somewhere in that ballpark, effective in preventing death in patients who get the full series of vaccinations when that was a double vaccination program. So they know those numbers, but they don't know a lot about vaccine development because we're not taught about vaccine development. How can we answer our patients' questions if we're not taught about vaccines? And if we're not taught about that in medical school, we can learn about it later. There's lots of CPD programs for doctors where we could have a session about this. And I haven't seen that happening. So even in the setting of the pandemic, I saw how we were supposed to tell all of our patients to get the vaccine. I saw these charts about the vaccine effectiveness and efficacy, but I wasn't mostly effectiveness, but I wasn't seeing a lot of informational pamphlets for doctors or CPD programs for doctors based on actually increasing vaccine knowledge. And we need it because it's a drug, and we get knowledge, we get training about pharmaceuticals, and vaccines are under that umbrella. So that's my big pitch for that. And this goes back to, providing good medical care. We need to have knowledge of the drugs or treatments that we are actually prescribing or recommending. I'm going to skip over this. I was very interested in this story, but I know we're running out of time. Dr. Steve James, who now will not lose his job now that the vaccine mandate has been rescinded. These are the questions that these are the statements that I think we can sort of meet our patients at when they come in being vaccine hesitant. These are maybe starting points, but just ask them, what questions do you have? Calmly, again, without the emotional engagement. How does your family feel about the decision? Because a lot of patients are getting pressure from their family not to. If they live in a family environment or a social environment where that's not socially acceptable, we know that peer pressure is tremendously important for whether patients are open to getting the vaccine. We can just tell them, I hope you get it. I hope you get it so that it it results in a lower chance of you ending up in the hospital or dying. So it's not a political statement. It's just a healthcare and a well-being and care statement. And finally, I end with, please consider it. I mean, I would say that to my patients. I've been saying it for years for the flu vaccine. We know that in smoking cessation, just asking patients to consider it actually helps. So I have no reason to think it won't help here too. So I'm going to skip over the next slide. If all that fails, we still treat our patients with respect and fairly, whatever their life choices and decisions are. So again, offering, we can't say we're not going to be your doctor anymore. I know some doctors in the US went on record saying that. That's not ethical. That's not allowable under the GMC, and we shouldn't do it. So with that, I think I'm just going to kind of end here. Okay. So we have a few minutes for questions. So with these are my summary statements that public policy differs from how we approach patients. So again, we don't have to come at it from a mandate standpoint. We're just having one-on-one conversations with people over and over again. Trust is critical. We have to take time to take the questions. I know we don't always have time in clinic, but when patients ask questions, it's an opportunity to engage. And then again, the CPD, continuing professional development thought there. So I'll end with that. And then should I just look at the questions, or Matt, do you want to filter them for me?
I'll do a bit of filtering, yeah. So what I'll say, folks, thank you first and foremost, Karen. That was absolutely brilliant. Really, really interesting. So, folks, if you look at the questions, we're not going to have time for all of them, but you can upvote the questions that you'd like to hear from. So if you want to crack on with upvoting the ones that you believe are most interesting, I'll start with this top one, though. So David asks, I'm curious to know what your views are on medical professionals who prefer not to get boosted or to get the vaccine. I think you might agree there's been quite some attention on this lately on the news about doctors and medical professionals that don't seem to want to get the vaccine. In addition to your views, would this decision seem to be a disservice or some sort of neglect of responsibilities that these healthcare professionals are exhibiting? Is it a personal choice and not for the benefit of the patient?
Yeah. So that's a tough question. I'm probably going to be a little bit more tolerant than maybe some of my colleagues. I come from most of my friends are critical care and respiratory doctors and feel extremely strongly this is absolutely not acceptable. So I kind of stand out in my group. But I think in regards to the Dr. James case, he said he'd been previously exposed and had antibodies to prove that. So I think if you're talking about someone who has what we consider to be natural immunity, I believe in our immune system, and I believe in natural immunity because it's true. I mean, this is immunology 101. But let's say someone had not been vaccinated and they're not being vaccinated. Yeah, it's a personal choice, and it's not a mandate, and it's not a legal requirement. So I still think they should be able to practice medicine. There are doctors who smoke. There are doctors who make lots of lifestyle choices that are not recommended, and they can still provide good medical care. So I just want to know, are they providing good medical care? Now, if they are not recommending the vaccine, or they're hinting at some concerns about vaccine efficacy that are unfounded, I think that's a problem, and that should be addressed head on.
Brilliant, thank you very much. We'll go straight to the next one. So this is one that I found interesting. Some guys got plenty of upvotes. Do you think the pandemic would have played out differently if there had been no social media?
Differently, yes. But yes. Yeah, I guess I should just say yes. I still think we'd be dealing with an endemic virus. And a large percent of the population is vaccinated, and we still didn't reach herd immunity. We were promised that would happen at 60%, then 70%, then 80%. So I'm not sure we're going to be. I don't think herd immunity is an achievable goal. I hope I'm being more pessimistic than I need to be. So, assuming that the unvaccinated portion is not affecting herd immunity, then yes. I mean, there are people that would have been vaccinated had it not been for social media and that have died. So yes, yeah.
Thank you.
I'll also say, can I just put this? I think social media also has good, and I think this was a very alienating time, and lots of people, were cut off socially from lots of different people, and social media also, or social fora, allow people to stay connected. So I don't view it as all bad. But in regards to the vaccine hesitancy part, then yes, it did have a negative impact and does continue to.
Excellent, thank you. This next upvoted one was one that I think you touched on a fair amount during the talk. What is your opinion on mandatory vaccination?
So beyond just healthcare providers? Yeah, it's tough. I so, enjoy the process and believe in the process of having patients feel empowered and making decisions, and not having a paternalistic sort of approach to that I'm not in favor of forced vaccination, but we know that it works, and we know that it saves lives. And so I'm torn. I'm going to be honest with you, I'm torn. I would not vote for a mandate. But I would vote, but then but then you're going to get what I really vote for, which is that we have more time to talk to patients about this and that we deal with poverty. Because as you saw, I mean, people who, lived in deprived areas, people that are unemployed, people that are socioeconomically disadvantaged are much, much more likely to be unvaccinated. And so I'm much more interested in tackling those issues. And I'm much more interested in giving us slightly more time to actually talk with patients and not be afraid of their questions because we don't have enough time. So that's the real problem in my mind.
Yeah, thank you. I saw a question, will this be recorded and published? Yes, it will. So we're putting all of our monthly lectures, as we always do, on our YouTube channel. Brilliant, thank you very much. Well, folks, I'm going to say that's all we've got time for in terms of questions are concerned. But thank you very much for all your questions that you posted. I'm sorry if we didn't get round to your ones. Thank you most of all to you, Karen. That was really, really interesting. Obviously very, very topical, and I'm sure it will continue to be so as well. Before we close the session, just a reminder that we do these every month. Next month's monthly lecture is being delivered by Dr. Finola Finity, who is a HIV and sexual and reproductive health doctor who will be doing a deep dive into the history of HIV. So I'm going to close the session now. Thank you very, very much again to everybody who attended. I hope you really enjoyed it. I know that I certainly did. And thank you again to Karen for a brilliant talk tonight.